Thank you. So one of my favorite quotes is, learn from the mistakes of others. You may not live long enough to make them all yourself. So with respect to my colleague Arash, let's just get that out of the way. So I'm here to talk about how we did a home-based cardiac rehab program at Henry Ford. And full disclosure, there's probably as many ways to do this as there are people in this room. And I would encourage you to take some of what you're hearing today and take it back to your facility and think about it and see how you could make it work within the infrastructure that you have. So why did we want to do home-based cardiac rehab? Do I really have to tell you? There's a huge utilization gap, right? We all know that. 20% of the people that are eligible for cardiac rehab are actually attending, even just one session. So there's a lot of barriers out there, some of which cardiac rehab can address: distance to a facility, program hours, things like that. Some of it can't address. We can't do anything about copays. Okay? They're still there. You charge for the session, they're still getting charged a copay. And we were told pretty early on by the insurers, you guys got an uphill fight if you're charging a copay for a home-based audio or telehealth visit. So hasn't come up yet, but we're waiting for it. So just going to talk a little bit about how we did this. Right? It says you, but it's how we did it, and you guys take what you can from that. So we want to talk a little bit about the laws that you have to kind of follow, just meeting with the insurance companies and how to maybe think about starting that process. How are you going to communicate with the patients, and then modifying the program? So the first thing you got to know before you start playing a game is you got to know what the rules are, right? So one of the things that we found was really interesting, we went to this website, and this would be a good time to take a picture of the screen, or if you write quickly, but it's the Center for Connected Health Policy, and you click on your state, and they tell you what the laws are for telemedicine in your state. And they brought it down to a level that an exercise physiologist can understand. Much appreciated. So we're here in Louisiana. So in Louisiana, you have to have two-way audio and video communication for it to be telehealth. In Michigan, it's audio, audio-visual or audio, which gave us some wiggle room here. Most of the sites that I looked at, the communication had to be synchronous. So that's real-time, interactive. Michigan specifically says that the client has to have opportunity to ask questions of the practitioner during the session. The other thing I'd encourage you to look into is find out if you live in a state with a parity law. And what parity laws essentially do is lay out the conditions under which private payers have to reimburse telemedicine visits at the same rate as an in-person visit. And in Michigan, and there's another website for you camera people, in Michigan, what the law says is that you have to provide equal reimbursement if audio and visual communication are provided during the session. So that's the minimum standard. If you have both, they have to pay you the same. They have to. But there's always some room for interpretation. So when you go and you meet with your insurance providers, you got to know the rules, right? And we, after going through the rules, there were really three issues that we had to kind of seek concessions on. And the first one was we had to agree that they would reimburse for the CPT codes we were going to use. And we're using the same CPT codes that most of you are using, 93797 and 93798. Because when you pull up the list of telemedicine services in Michigan, those CPT codes aren't on there. First hurdle, will you reimburse for this even though it's not on the list? Turns out Health Alliance Plan, which is Henry Ford's own insurance company, and Blue Cross and Blue Shield of Michigan both said yes, we'll reimburse. It's also really, really useful if you can identify somebody within the insurance company to act as a liaison, if you will, to help you track down whether or not the bills are going through the way you expect them to. This is pretty outside the box. And if you've ever called an insurance company and tried to figure out if something's covered or not, it's not easy. Okay, and when it's outside the box, it gets harder. And when it's this far outside the box, it gets really hard. And what we found is pretty useful is I have a gentleman who's a vice president of Blue Cross Blue Shield, and I can call him up and say, George, yes, Bob, I'm having a problem with this claim. Can you look into it for me? And he goes top down. It's much easier than trying to explain to whatever random person happens to answer the phone. Well, we've got this program. Okay. The second thing that we had to get a concession on was that the service could be provided in the patient's home or community setting. Historically, telemedicine is usually done in a clinic or some facility, and the intent was it was too far to go to the hospital and get the service done, but maybe there was an outpatient clinic and you could go there and have something done. If they can go to an outpatient clinic, they can come to a facility-based cardiac rehab program. Right? So we had to get a concession there. They're okay with it. Interestingly enough, in the bundled payment that was announced, this geographic site requirement has been removed for CABG and MI. So that opened up the door just enough for a little bit of light to get through that someday maybe Medicare will think about this, maybe. And the last thing we had to talk about was an agreement on the method of communication. So if you were really paying attention, and I'm not sure, I wouldn't blame you if you weren't because it's lunchtime, but if you're really paying attention, the Michigan law says telemedicine is audio or audio-visual, but the parity law says you have to have both. How do you kind of rectify that? Well, the parity law says what you have to pay for. The insurance companies have the discretion to pay for it, even if you aren't meeting those conditions. So secure video communication is a little bit trickier than a phone call. So when we launched this in early July, so we're just a couple weeks behind Mary, we didn't have the capability to secure video, and just business Skype wouldn't cut it. So what we're actually, right now, today when we're doing this, it's just on the phone, and Blue Cross Blue Shield and HAP are both okay with that, with the understanding that we're progressing towards real-time audio-visual conferencing. So on the upper right corner is a Henry Ford MyChart app. You'll click on that app, you'll open up a video camera, you'll turn your selfie camera around, and you'll see the provider at the top, you'll see the patient at the bottom, and it's going to protect the privacy of the patient. And I'm getting the 1-minute sign, so we go to the last slide. Modifying the program, yet still meeting industry standards. This is actually the easy part, believe it or not. You guys know how to do cardiac rehab, and you know what the industry standards are. So determining what patients you think are eligible, how you're going to monitor them, the exercise prescription, you guys know how to do that. What we heard loud and clear from Blue Cross Blue Shield of Michigan and HAP, the documentation's got to be the same, and you got to be tracking the same outcomes. You do those two things, and we'll pay you the same. So I think I'm done, right? Thank you.